Hello, everyone. Happy Thursday. Welcome to yet another edition of VMR. Today is a strictly internal affair, as I was saying to the team. We have Sarah, who's back scribing. Hello, Sarah. Ashutosh, who's doing teaching points for the second time around, all the way from Nepal. A VMR legend and guru, an appropriate tie attire proportional to his status in VMR. Andrew Sanchez is presenting a case. And last but not least, I get to co-discuss with Gia, who I think you all have gotten to know through her um, quite emphatic presentations on VMR. Ironically enough, first presentation to Andrew. And as you all know, is customary, I think when people make a tremendous impact on the inside of CP solvers, it is our tradition to have them come and tackle a really complex case in front of a crowd, which may be counterintuitive and may seem like more punishment than it is celebratory, but this is what we love to do, and I know Gia's up for it. It's been really, really cool to see you thriving, Gia, in so many ways, and to my surprise, more ways than others. And Gia and a couple of three or four other people are working on some really innovative things that I think you will see the surface of. But I'm very, very excited to co-discuss with you, Gia. And I'm curious to tap in how you're feeling since I think this is the first time you've done, well, actually, I know this is the first time you've done so on this stage. How are you feeling?
Yeah, I'm actually for this co-discussion. I'm very nervous. I just
Yeah.
describe it as like a surprise box for for OSCE that I don't know what case I will encounter. But once I've realized that you always on my back, kind of navigate us to this case, I feel more relaxed and see it as a great learning experience.
Oh my gosh, it's probably really a jolt for people to hear that you're nervous because I've listened to the last two of the last three VMR recaps, and I think you come off as nothing but smooth, polished, and pristine. And so I think it's just inherent to the process, that you're discussing publicly as something that you don't know. But I know we're set up for success because Andrew is here in the middle of his inpatient rotation. Andrew, what's up?
Hey, it's good to see everybody. So many faces today. Thanks everybody for being here. It's really special because you all are always showing up. So appreciate you.
Well, Andrew, I know your cases are bamboozling to say the least, so I think we should jump right in and hopefully leave time at the end to reflect and come full circle to this conversation. So take us away, my friend.
Okay, you got it. So aliquot number one. Let me just get my notes back here. So this is a man in his 60s who was brought to our hospital by EMS due to concern for seizure. EMS says the patient was found on the ground of a store. There was not a witnessed fall. He was communicative but clearly confused the situation. However, he does say he thinks he had a seizure. On chart review, there is a recent diagnosis of late onset unprovoked seizure disorder with a prior workup notable for a negative MRI brain. And I'll stop there.
Yeah, Gia, I'm really curious to tap in to what you might be thinking in real life now. Say this is just the first few moments and you're standing right by the ambulance door and you're hearing this history. What thoughts might be crossing your mind?
I would firstly think about whether it is a real seizure, especially for sure this patient has a history, but we have to see whether this episode is caused by seizure or any other things that are similar to seizure that caused by, for example, by the sugars, by all the like substance, the 6 A's we have, like we discussed before, and also very important to distinguish the seizure with the syncope and stroke and this similar neurology stuffs. That's my initial thought.
Superb. I completely agree with you. And I'm curious how much doubt you cast upon the diagnosis of seizure is based so much
Yeah.
on what happened to the person, but also what happened before they had a seizure. And so in this case, we have a lot of information to say that he was diagnosed with late onset unprovoked seizures with a negative brain MRI. If we just focus on that piece of data, that he's got a diagnosis of late onset seizures with a negative MRI, how is that helping you adjust your confidence of whether this is a seizure or not?
Mm. I would say that first we kind of rule out some major structural things by the MRI, but I would still suspect it and also want to know whether there is the electronical brain workup has been done before.
Right. I think it's really tricky, as you said, because we are given that the patient has a seizure disorder, yet has a normal MRI. And fundamentally, the question becomes, how can you have a seizure disorder with a negative MRI? And your first instinct was to realize that maybe this is not correct. Maybe that the seizure disorder is actually a mimic of something else, and that's why the MRI brain is negative. But you also said that a patient might have an electrical issue primarily without any structural findings. And I think that's just so telling of what we do in a patient who has a heart seizure, or otherwise known as arrhythmia. We get an echo or even an MRI. And if that is normal, it doesn't mean the patient did not have an arrhythmia. They could have had something like Brugada syndrome or long or short QTC. But certainly, the range of possibilities in a patient with seizure is now much smaller with a normal MRI. And so there are two possibilities. Either there's a microscopic focus of seizure, or there is no focus of seizure, and that is wrong. Of course, there's the caveat, Gia, that the MRI was done and it is perfect. It easily could have been done with not the right protocol. For example,
Mhm.
for seizures, there are specific protocols like the cortical protocol to detect a small abnormalities. So that could be possible for sure. So maybe you can give us a sense of if you're standing there and you're getting this history, what observations might you be making just looking at the patient without examining them, but maybe just from watching them from afar? What would you be looking for?
I would be looking for like some post-seizure symptoms, any like urination loss or any incontinence, such things, or any tongue bite, such like clues for seizure.
I completely agree with you. And if you had to teach us, which one of those things would you find the most valuable? Tongue bite or urinary incontinence? What do you think would be most helpful to you?
I'm not so experienced at that, but I would guess probably tongue bite.
Yeah, exactly right. Your instinct is correct. It turns out that urinary incontinence, unfortunately, has very poor predictive value to distinguish between seizure and syncope. And so a tongue bite would be very, very valuable. I completely agree with you. I think that what would probably happen next is you would probably get a finger stick glucose and do a good and very thorough exam. Any other thoughts or questions you wanted to share before we get more information from Andrew?
I think you give a very wide discussion on that, and I'm looking forward to future clues. Yeah.
Okay, alrighty. Andrew, the mic is yours.
Awesome discussion, you two. Amazing. Just for clarifying information, the negative MRI brain was kind of done as like an outpatient kind of chronic, workup, just to be crystal clear about that. And the finger stick is negative when EMS finds them. So here's aliquot number two. So on review systems, the patient believes his last seizure was about 1 month ago. He does not have weight loss, high fever, night sweats, myalgias, arthralgias, chest pain, dyspnea, or other remarkable symptoms. He says he's a generally healthy guy who lives with his partner and dog. He has no other pets. He used to be a construction worker, but since the seizure disorder diagnosis, he's retired. He spends time outside doing home repairs near the woods. For his unprovoked seizure disorder, he takes Depakote, oxcarbamazepine, and zonisamide. His neurology notes show EEG confirms multiple seizure types, and the history is notable for a related motor vehicle collision, as well as nocturnal seizures witnessed by the wife. His initial seizures about 10 years ago were notable for no prodromal symptoms, whole body stiffening, loud moaning with rhythmic vocalization, bowel incontinence, tongue biting, and subsequent confusion. His first lasted 10 minutes. After starting anti-seizure treatment, his seizures became less severe and were marked by eyes glazing over, staring, body wobbling, and then loss of balance resulting in fall. And that's aliquot number two.
What are you thinking now, Gia? What are your thoughts with this information?
Yeah, I'm very curious why this patient already on this anti-seizure medications, but still have this episode. Is there any like etiology underlying for that? Very like whether this patient is adherent to this medication, any changes in this medication? Yeah.
Yeah, I completely agree with you. I think that that's going to be really key is he's prescribed medications, but are they making it into his bloodstream is I think a very important aspect of this. If you had to sort of ask yourself how strongly you believe that he has a seizure disorder now, would you say you're more confident than before or less confident that he in fact has a seizure disorder?
I would say I would kind of more confident
Yeah.
because the patient is response to the treatment. The treatment can give us very
Yeah.
good, great evidence. Yeah.
I completely agree. You're getting such a classic story of seizure presentations. They're nocturnal, they're characteristic rhythmic movements, and most importantly, they've been responsive to treatment to some extent. Of course, just because you've had a seizure disorder does not mean that every time you're found on the ground you seized. It could be that you have something else currently. But I think the ground that we're standing on now just became much more firm that he does have, in fact, a seizure disorder, making it more probable that he sees today, but not impossible that he had something completely unrelated or that he has non neurological consequences of a seizure diagnosis. Um, so I think that that thinking is absolutely superb. Um, and uh, in terms of studying these medications, um, I'm curious if you have a sense of what you might do with that information in real time. And maybe we can actually just step back and ask a broader question. So now that you've gotten this data, you're going to get the
Mhm.
exam, but what might be your initial first set of orders that you would put in? Because in these situations, often we're actually tasked with quickly putting some blood work and then going and doing an exam as the nurses and our colleagues help settle the patient, get them in a gown and get an IV. So if you're at the computer now, what do you think you might be putting in?
I don't know. Can I like test this medication's concentration in the patient's
Oh,
blood? Yeah.
excellent. Excellent. Yeah, in addition to the usual testing, I think that you would probably get a whole workup. Um, and in addition to that, I think scrutinizing the levels of these medications, some of which you can
Mhm.
measure, other of which you can't, unfortunately. Um, if I had to ask you out loud, how would your workup for altered mental status be different than your workup for seizure in terms of what tests you get? What do you think?
I think if I have to work up for auto status, probably I would put it in a like wider settings to work up for some probably let me see like the electronic like the electrocytes staffs and also like the myths like infections and toxics
Yeah.
substance such stuff in a like wider setting. Because I think seizure is kind of narrow diagnosis that if we want to put our differential diagnosis more wider, we definitely should test more wider.
Yeah, I think that you're right that when somebody has a seizure, there's something a little bit more specific going on. So if you take altered mental status as an example, in most people who are on internal medicine, altered mental status reflects diffuse cortical dysfunction. The whole cortex is dysfunctional. In contrast, seizure disorders represents a focal often cortical issue. So the question is, how does it influence your workup if you have a diffuse cortical issue versus a focal
Mhm.
cortical issue? And it turns out that initially, not so much, because what happens is that the same metabolic, infectious, or toxins can, instead of triggering a diffuse cortical depression, causing a patient to be confused, they can actually activate that vulnerable cortex. So anything that you can think of that causes altered mental status can also cause a seizure in a patient who has a focal, either macroscopic or microscopic focus. Hyponatremia, you can seize. Hypercalcemia, you can
Mhm.
seize. Hypoglycemia, you can seize. A UTI in a patient with a structural lesion can seize. A patient who is withdrawing from alcohol can seize. So the workup initially is fundamentally identical, with the exception that you have to add on drug levels for patients with seizures, and the medications that cause altered mental status are at play, but also there's some very specific medications that influence the seizure threshold. So, for example, Wellbutrin or bupropion won't cause altered mental status, but it will certainly lower the seizure threshold for
Mm.
patients who are vulnerable to it. So initially, you can just, if you have an order set that you order for altered mental status, just click it. And the only things you'll have to do in addition are to measure drug levels for seizures and also to look at the medications, not for altered mental status, but if they influence the seizure threshold. That's really a carbon copy of what I do all day. But I also order some benzodiazepines just to be ready. Because if the
Mm.
patient is going to seize again in front of me, I don't want to wait the 3, 4 minutes it takes. So I just order them right now and ask the nurse to hold on, and we can use them if needed. Any
Yeah,
questions
that's
about any of
very
that?
excellent. Yeah, I forget the thing that the interactions between medications, and that's very important to consider. Yeah, and also prepare for any urgent situations like the re-seizure again.
You're just like you're doing in your teaching recap. You're summarizing so well. I love it. Thank you.
Thank you.
All right, Andrew, back to you.
Okay, I have two aliquots left, and both have a decent amount of information. So for aliquot number 3, the patient was afebrile, 120s over 80s, normal respiratory rate, and normal saturation. On neuro exam, he was initially oriented to self, but not location or situation, and the remainder of the neuro exam was non-focal. For his heart exam, he had no murmurs, his lungs were clear. And then for his skin exam, he did not have any lesions throughout the entire body, and there was no palpable lymphadenopathy. For labs, he had a normal sugar, normal BMP, normal white count and diff. He had a borderline macrocytic anemia to 12.5, no thrombocytosis, normal coags, ESR of 2. His Depakote and oxcarbamazepine levels are mildly low. And a non-con head CT shows a left frontal 2.4 times 1.3 centimeter ring enhancing lesion, a left temporal lesion, and a right temporal lesion. And a confirmatory MRI is done that shows 4 T1 hyperintense lesions with surrounding edema and central restricted diffusion. There are small bilateral subdural fluid collections. The infectious diseases service is consulted for further evaluation, and then given stability, no antibiotics are administered. And that's the aliquot.
Dr. Sanchez, oh my gosh. I was just sitting here thinking actually early on, but didn't say it out loud, that I just can't let go of the fact that we got to witness your growth as a physician on VMR, literally from your third and fourth year of medical school to now, and you seamlessly presenting such a complicated case. And knowing you, I was like, where's the mic going to be dropped? It's going to be very strategic and very calculated and very wise. And here it is, Gia. Um, yeah,
Yeah.
if you now had to practice one thing, which you'll have to do next year for sure, is to sort of update your problem representation or just simply your mental summary. What's your mental summary of the patient so far?
I would say this is like 60-year-old male with history of seizure and present to the hospital suspicious of seizure, but then further workup labs almost normal, but we found some green lesions in his brain, and his like MRI like 1 month ago, this was totally clear.
Yeah, 100%. I think it's really such a wise approach. And before we start to try to think about the brain lesions, I'm curious what your speculation is on. Do you think he's had this problem all this time and that's why he was seizing? Or do you think that this problem just developed recently? Or what's your sense of how to connect the novelty of the brain findings with the long-standing seizure history? How are those mapping on for you?
I would say that currently this case seems to me that there are two situations overlap. That's the history of seizure and this new finding of brain lesions. I would not say that like the one situation conditions because the patient has history of seizures seems for a very long time and on these medications. And currently this new findings appears. So I would definitely think about different things happened.
100%. I think I completely agree with you. It's really powerful just to see the story evolve and to see how just because a workup has been done in the past does not mean that the patient can be unlucky enough to get a separate disease process that could slip up under that previous workup. But I also think that these are the times where a conversation with our radiology colleagues is so helpful because our radiologists are amazing, but they're not perfect. And so if you now go back and look at his prior imaging, will you see something because of the benefit of knowing what happened, or will you not? So I think I say that because we're going to spend the time talking about the brain lesions, but I will tell you the time course of the brain disease is going to be so important. So if we learn later that actually these were apparent on MRI, but they were too small for to be noticed initially, then we're dealing with chronic, slowly progressive brain lesions. But if we
Mhm.
learn that actually they're relatively new, then the possibilities are very different, right? But I think we
Yes.
should probably start with the assumption that they're new because the patient is so much more overtly symptomatic. So I'm curious, if we assume that they're relatively new, how would you begin to think about them?
I would like focus on the brain lesions but actually these terms remind me of some infections, but very weird to me is these patients don't have any other signs for infection, like the temperature is normal, the labs white blood count is normal, and yeah, very and also I would consider malignancy like lymphoma and in such age of patients.
I think that's absolutely superb. While there are other things that can cause brain lesions, including some autoimmune diseases,
Mhm.
and some vascular issues, the most common differential diagnostic entities that we have to entertain are infection and cancer by far and away. Um, and so I'm curious, with the MRI findings, do you have any sense of which one you're leaning towards, infection or cancer, or is it kind of equal for you?
Mm, I would say probably infection because there is surrounding edema, like but yeah, just a sense.
Yeah,
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 such words like reminds me of inflammation.
I
Yeah.
agree. I think there's three things to help you understand when you're trying to look at a brain mass. Three things. The first thing is, what are the consequences to the adjacent structures? And
Mm.
so is there mass effect? The second thing is, what is the pattern of enhancement? The third thing is, what is happening on the inside? So when you're studying a brain mass, you want to know what's happening outside,
Yeah.
at the wall, and inside. Three things. Mass effect, rim enhancement or no rim enhancement, and inside, is there diffusion restriction or not? Diffusion restriction either equates with pus or a highly necrotic tumor. Both those
Mm.
states cause stasis of water, lack of motion of water, and that shows up as diffusion restriction. So, while a necrotic appearing tumor can mimic this exactly, the presence of central restricted diffusion is more in keeping with an infection than it is with a cancer, though a necrotic tumor would be very plausible here. It's also important to see that there are consequences beyond the mass, including collections of subdural fluid. And this also implying that the process, likely infectious, has seeped into the subdural space, I think further increases the probability of an infection. So, Gia, what do you think you might do next to try to get to the bottom of what's going on?
I would say probably do definitely do some infectious workup and like the HIV and any infection like can involve the brain, like the toxo, and also ask history, like any travel history and any contact history, and probably I'm not sure that in this case should we get biopsy, but I think that's very invasive and should be like the final step we can consider.
Yeah, I agree with you. I think it's very telling. Um, to think about the kinds of infections that do this, and they're usually exogenous infections from outside the body, like the things you're alluding to. I will tell you the first step is to try to understand the systemic fingerprint of this disease. So, in other words, we're staring at this person's brain on the screen, scrolling up and down. But what we really need to do is to look down and look down for a peripheral cause for these lesions to go. And there are three places that are common sources of brain masses. The lungs. The lungs are the portal of entry for many of the infections you implied. The lungs are also the source of the most common cancer metastatic to the brain, lung cancer. The skin. This could easily be a small melanoma on his back that he has never seen. It could also be the portal of entry for very rare but important infections like spirotrichosis, for an example, or some kinds of nocardia can come through the skin. So the skin exam is really, really key. And also the liver. The liver is the least common, but there's some very rare circumstances where an infection in the liver can make it over into the brain. And we actually had that rare example when Yuki from Japan presented a case to Jimena and I of a Klebsiella liver abscess that went to the brain and the eye. So for me, I'm most interested in looking down at the liver, at the skin, and at the lungs most importantly. And in the lungs, we'll either find another infection, another cancer, or we'll find an immunocompromising condition, such as structural lung disease or rare protein issues that may explain why this person, out of the blue, has masses in his brain. So first step, look down. As a side point unrelated to this case, if you're worried about an autoimmune disease causing brain masses, like acute disseminated encephalomyelitis, in addition to looking at the lung, skin, and liver, you would consider imaging the spinal cord because there is very few things that cause brain lesions and spinal cord lesions except demyelinating diseases. So that is an option on the table, but these masses look so aggressive, infectious, or malignancy that I probably wouldn't do that off the get-go. But if we go wrong, an MRI spine might be something in the future. So big piece of advice, look down. I think that's the key.
Got it. Like to see whether this is a primary things in the brain or like spread by secondary other size infections.
Exactly. Like toxo, nothing downstairs. Neurocysticercosis, nothing downstairs. Lung cancer, many things downstairs. Yeah. Alrighty, Andrew, tell us more, please.
Ooh, nothing gets past you two. Okay, I have answers for all your questions. I'll just reiterate the skin exam. Checked in between the toes, did the Dr. House exam. There's no melanoma. Great thought, Rabih. And for further MRI information, I'll just comment that all the lesions are abutting the inner surface of the skull, and the largest is 4.1 centimeter. For labs, HIV blood cultures, syphilis screen, toxo IgM, IgG are negative. For further imaging, he got a pan scan, a CT with IV of the chest, abdomen, pelvis that was negative for signs of malignancy or abscesses. A TTE was negative, and PSA testing was negative. So given lack of clarity and concern for malignancy, a brain biopsy is performed. This showed hemorrhagic and necrotic tissue. All infectious stains and cultures were negative. He was discharged off antibiotics, and a repeat brain MRI showed significant interval decrease in resolution of the ring-enhancing lesions. And that's the final aliquot.
Oh my gosh, yeah. What are you thinking?
Wow. So like the biopsy, did we get the final diagnosis or just some unspecific findings?
I think you'll get an answer.
Oh, got it.
Yeah.
So, I would think since all these workups kind of rule out the other infections in other organs, but the hemorrhagic and necrotic tissue, I would I still can help us to distinguish whether it is infection or whether it is malignancy. Yeah, but there is a decrease in size after this discharge without antibiotics. Probably, I would think whether it is a like wall-off infection, like once we get it drained, it kind of resolved, or whether it is like malignancy. I'm not sure.
Yeah, yeah, I'm also very, very stumped by this case. I've never seen anything like this before. And I think the thing that I would study the most scrutiny is to watch this disease get better. And sorry, Andrew, Nar was barking a little bit while you were presenting. I think the summary was that he didn't get any specific treatment. Is that right? Or did he get, okay, he didn't get any specific treatment. So I think we're essentially trying to solve the problem. Gee, I think the most specific problem to try to get to the bottom is to say, what causes spontaneously resolving necrotic and hemorrhagic brain lesions? And I think the question we have to think of is, do any infections get better by themselves? Do any cancers get better by themselves? And what are your reflex thoughts to even asking that question? What do you think?
I would not think like malignancy can resolve without any treatment, but for infection, because I just noticed we just did a biopsy, not some drainage, so I feel like still wild, like whether it can get resolved. Yeah.
Yeah, I'm starting to wonder what I think the spontaneous resolution of a malignancy is actually an interesting phenomenon. There are some tumors that will actually spontaneously regress. I first saw this in real life in a patient with a rare tumor, not a rare tumor, a rare event of a common tumor. There's a tumor called a keratoacanthoma. It's a tumor of the hair follicles that sometimes grows so fast it kills itself off. And then at my hospital, there was a case presented of somebody with metastatic HCC who spontaneously improved. And I learned that, immunotherapy, which I know that you will be an expert in, given your future career interests, Gia. Um, Sometimes your body can turn on the immune system by itself. Cancer accidentally exposes an antigen, and your tumor will regress. And there are these miracle cure cases of patients with widely metastatic cancer for whom their cancer vanishes away. So is it possible for cancer to spontaneously regress? Unfortunately, the answer for our thinking, fortunately for the patient, is yes, it's possible. Um, and so I think that we'll have to entertain. Is it possible for an infection to spontaneously regress? And I think the answer for an infection that is this deep in the body is probably no. Of course, most infections do spontaneously resolve. UTIs spontaneously resolve, pneumonias can spontaneously resolve, but I think an infection that made it this far and this deep to get better by itself, it would be new learning for me for sure. So we can entertain the possibility of a tumor that spontaneously improved, but I don't know how we would ever know that for sure in retrospect. So I think we have to maybe take it up a next stage and think, okay, what other things can cause brain masses? So if we go back to that original schema of like, what else do you think might cause a brain mass? In addition to infections and tumors, what might cross your mind?
Is there any like autoimmune etiology? I'm not very sure which kind of conditions can lead to that, but I think it's a possibility. Yeah.
Agreed. Yeah, there are a whole variety of autoimmune conditions that can result in brain masses. It's helpful to stratify them as systemic diseases that go to the brain, like
Mm.
sarcoid, antibody-mediated diseases, of which there are very few, um, uh, demyelinating diseases like acute disseminated encephalomyelitis, or its cousin called acute hemorrhagic leukoencephalitis, which this would be an interesting hypothesis to think about in this instance. And then finally, vascular disease, so vasculitis causing brain masses like primary CNS vasculitis. There's also the possibility that trauma can result in subdural collections and cortical brain masses. And the idea being that the brain unfortunately heals with liquefactive necrosis. So if you injure your
Mm.
brain, you just develop a hole in it, unfortunately. Um, and so the things that I would be thinking about I would just say my confidence level on this case is very low. But going back to that sort of master schema of infection, cancer being priority, I think spontaneously regressing tumors are very interesting, but usually the patient has a known tumor that then spontaneously regresses. I don't know how you can prove that this was a tumor without re-examining the tissue more closely. The other possibilities are that this is a spontaneously resolving autoimmune disease like acute disseminated encephalomyelitis or its hemorrhagic cousin, AHLE, acute hemorrhagic leukoencephalitis. But I wonder if this is a phenomenon that might be described in patients with severe trauma. Say he bonked and hit his head really badly, and that he has subdural hematomas, and that this is a phenomenon that extends to his cortex. So I would probably be trying to look that up and think about that, but I've never seen it. I'm just kind of thinking through analogy here. I think we have a lot to learn from Andrew. This is a very, very cool case, but I'm curious, Gia, if you have any final thoughts before we pass the mic to Andrew.
Yeah, I think you what you said is totally right. If like our initial thought for infection and for malignancy seems not fit the picture, definitely we should jump out of our original thoughts and see any other possibility. And I think your thought of this any trauma and its related lesions is a very interesting one because I think like for the older patients that they kind of have some trauma very frequently and yeah, it sounds very reasonable for me.
That's awesome. Me too. That's awesome. I'll just point out Yasmin in the chat is picking off of Reza and saying, Rabih, you're not confident in the diagnosis. And she's pointing fun here. We also were not confident in the diagnosis here. I think I have a good answer though with that interval event. We weren't confident in the diagnosis, but neurosurgery reevaluated this whole case and left the final diagnosis that I think is pretty reasonable. So the final diagnosis was multifocal traumatic CNS contusions and hemorrhages due to recurrent falls related to seizure. So I think the big clues to make this diagnosis, Rabih used the word cortical, which I think is just a fancy word for like, closer to the outside of the brain, like abutting the skull. So if you see a bunch of ring enhancing lesions and you can like put your hand like over your forehead or over in an area and kind of like all the lesions like line up, I think you can think of someone bonking their head like Rabih said. And of course, you can fall multiple times and hit different parts of the head. But this patient, most of their lesions were in the front, and the subdural hematomas bilaterally was kind of also a little bit of a red flag that, these were subdural collections from falls, actually. So yeah, you guys hit on the major DDX for ring enhancing brain lesions. There is Mariana put in the chat earlier a mnemonic for this that's very extensive, and you all covered the etiologies. The DDX for ring enhancing brain lesions is Magic Doctor. So going through by letter, it's metastasis first, which you all discussed extensively. This is usually at the gray-white matter junction. Abscess you all discussed extensively. G is glioblastoma, and I think with that you can group CNS lymphoma. I is for infarction, subacute stroke, and inflammatory diseases like sarcoid. Now, C is contusion. I think this is the one that I certainly didn't appreciate. And it's a pretty long mnemonic, so you can get lost in it pretty quickly. But I think the learning point from this case is you can save people a brain biopsy if you have a really, really good clinical history for something like recurrent falls, like seizure. So if there's nothing concerning for infection or for cancer in this patient, such as this patient where we pan scan them, we sent all the infectious studies, everything was negative, maybe someone out there is confident enough to actually not do the brain biopsy. So C is for contusion, D is for demyelinating diseases, and then R is for radiation necrosis. But super challenging, interesting case. I was surprised to see the result. I wasn't sure how it was going to pan out after I added them to my follow-up list. And yeah, I'm curious for your reflections.
Gia, what do you think?
Yeah, I'm very surprised to see this diagnosis, and actually it's my first time to see this diagnosis and a very interesting one. And I think that's really kind of fit this picture because I think this patient like with a dominant complication of seizure and like dominant CNS things, but otherwise all these labs and other like RAs kind of all negative, and this like Yeah, this diagnosis is very like amazing to me, and I'm sure I have to do more readings about it.
A similar sentiment. I think, Andrew, this was such a powerful case and a really, really cool story to share. And I think it's amazing how you can, when you look back on it, like, oh yeah, totally. Like it really adds up. It makes perfect sense. And the signature of the disease is there. There are subdural collections, and then all the lesions are either in the frontal or temporal lobe where patients bonk their head. Um, I find that really, really cool. And it was also just really cool to see two things. One, how just the fact that you guys were so thoughtful in the initiation of antibiotics that if you had given this person antibiotics and in a very extensive manner, I think it would have really clouded your interpretation of the subsequent data. And I think you set Gia and I for a much more productive conversation by being able to answer the question, what causes spontaneously resolving brain lesions? And this goes to show you the really, really tricky circumstances that we find ourselves in the world of empiric treatment. And empiric treatment is basically treatment when you don't know what the cause is. And of course, the benefits of empiric treatment are you could save the patient's life. And that's why we do it in critical situations like sepsis. But the downside of empiric treatment is it clouds the interpretation of subsequent data and impairs your ability to see things crystal clear without manipulating the story. And if you guys had manipulated the story with antibiotics here, I think you might not have presented this case today, and we would have lost the pure confidence by which you can make this diagnosis. So the big lesson for all of us is to ask ourselves, like, why are we initiating treatment right now? And in a patient who looked like he was getting better and waking up from a seizure, I think taking your time and really being thoughtful about, is the patient sick enough to get empiric treatment? Because here you would see a massive downside. But I think another big lesson is something that Andrew slipped in there, which is the only reason we're getting to learn this lesson is because Andrew, you put this patient on your follow-up list and followed up on him. And I think that's just so telling of the budding master clinician you're becoming, to know that you got to follow up on people. So I'm curious what your reflections are, Andrew, but also maybe you can take a moment of what advice you've learned over the course of residency in tracking patients and how you might advise others to do the same.
Oh, that's an amazing question, Ravi. Well, I learned from you through Dr. Dhaliwal to do that. So yes, very productive. I'm really happy I started doing that my intern year. A senior resident also encouraged me to do it. My advice for people starting residency is to even start subdividing the list early, because I used to have one list of just like interesting patients, and now it's like 200 patients long. So you could stratify things by like diagnostic follow-up, like you discharged someone or you saw someone without a certain diagnosis and you want to follow that up. I think RX follow-up is also really important. So you felt pretty confident in a diagnosis or a treatment, but you still add them to like a treatment follow-up list to make sure they got better or that the initial diagnosis was correct. I have like a close patients list for patients I just developed really close relationships with, and I can check on them later too. And then on top of that, just like the super interesting cases, I have a list of them too. So I think there are a lot of different ways to track it, but it's definitely very productive. So I'd recommend it for everybody for sure.
Amazing. I'm so glad. I'm so glad you're able to have done that and to share this really, really cool case. I can't wait to reflect more and enhance my understanding of this space. Gia, how did it feel for you?
Yeah, I think this experience was like just amazing. Yeah, and not only we got like such a wonderful and involves a lot of reflection in this case from Dr. Andrew, and also I think like the whole process with the discussing with you is very like kind of when I really experience this process is not so pressure, not so stressful, and I'm here just navigated by you to analyze this case. That's yeah, very amazing.
Oh, you didn't need any navigation, my friend. I was just asking the questions and you had absolutely superb answers to all of them. It was a real pleasure. And I already am looking forward to the next time we get to do this. But in the meantime, I'll pass the mic to Ashutosh to kind of recap the highlights.
Hi, everyone. Can you hear me?
Yeah.
Okay, so we had an amazing case today, a lot of learning. Thanks, Andrew, for bringing this case. Our patient had seizure, so we first jumped on to the discussion of is it actually a seizure or a seizure-like episode, which is most commonly seen in syncope, and if it is seizure, whether it is provoked or unprovoked. So differentiating seizure from syncope, we learned that tongue bite is more helpful compared to urinary incontinence. Our patient had an MRI negative seizure. So there are two possibilities whenever we have these kind of conditions. Either the focus, either the pathology has very small focus, like of abnormality, or it is not a seizure and another condition that we have misdiagnosed. We also discussed about evaluating how should we approach a patient when we are evaluating seizure. So which basically comes down to our thought process of whether the seizure is provoked or unprovoked. We should start working up with electrolytes, glucose, measuring medication level if the patient is already on any anti-epileptic drugs. Getting a urine analysis, urine toxicology, serum toxicology is also equally important. Eventually, the seizure is diagnosed by performing an EEG and MRI to look for structural causes. We discussed about altered mental status and how the pathology is different in altered mental status compared to focal seizures, because in altered mental status, we have diffuse cortical issues. Even though the pathology is quite different, the initial workup might be very similar, as we would also order all these investigation in case of altered mental status. Regarding certain medications, like bupropion, which can reduce the threshold of seizure, it probably wouldn't cause AMS. So this is why getting a medication level is even more important. At the same time, when we have a patient who is actually seizing, ordering a benzodiazepine is a good move. But we can probably wait for a while before administering it. We also discussed about the findings on imaging, and it is always a good idea to compare it with the older findings to find out whether there are any new findings or not on the repeated imaging, which can guide us to know whether the pathology, whether it is the actual seizure disorder which is causing the seizure in the current episode of seizure, or is there any superimposed infections or cancer or any other condition. When we see an imaging of brain, we need to be mindful of what is outside and what is inside. With the which means that it is very important for us to look for mass effect, ring enhancement, and what is wrong in the parenchyma. Diffuse restriction, which was actually present in our case, represent pus or highly necrotic tumor, which reflects that there is lack of motion of water. Central diffuse restriction, which was the case in our patient as well, usually points toward infection. And subdural fluid collection could also be secondary to infection. It is very important whenever we find a finding on a brain MRI, it is very important for us to look down and look for the peripheral causes of brain mass, like lungs, which can show cancer or immunocompromising conditions, skin, which can show like melanoma or nocardia, and also liver, which can show like abscesses, especially the Klebsiella causing that abscess. Looking at the spine, performing an MRI is also important because there are certain conditions, mostly autoimmune, which can cause demyelination in both brain and spine. Autoimmune conditions that can cause brain mass can include sarcoidosis, acute hemorrhagic leukoencephalitis, and vasculitis as well. We also discussed about what can potentially cause a brain lesion that is spontaneously resolving, as it was in this case. We learned that some tumor, which might sound surprising, can regress, like keratoacanthoma and metastatic HCC. This is basically like immune system working at its best. It recognizes the antigen present on the tumor cells and resolves the tumor. infections are less likely because especially when the infection is this deep in the body, it is less likely to get better by itself and spontaneously resolve. We also learned about the mnemonic of ring enhancing lesion, MAGIC DR, where M stands for metastasis, A for abscess, G for glioblastoma, I for infarct, C for contusions, D for demyelination, and R stands for radiation necrosis. Empiric treatment is very important when sometimes because it can help us save the life. But the downside of empiric treatment is that it can mask the diagnosis and we might not know what was actually the cause of the patient's presentation in first place. And we also had this amazing residency tip from our Andrew that it is very important for us to follow up with our patients to learn more and get a better understanding of their overall health.
Yeah, how did he remember all of that? That's incredible. That's so cool. Fantastic job, Ashutosh. That was really, really cool. I'm so impressed that you remember everything in Magic Doctor. I still have to like rehearse it one more time. That was really, really cool. Well, thank you, Andrew, for an unbelievable case. It was a real treat. And soon enough, Andrew and I will be in the co-discussion seat together next month. So if any of you have a really cool case to thank Andrew, please consider submitting it through the case review committee. Um, and there, you might bump into many other CP Solvers team members, including Gia, who just absolutely did a really amazing job today. So thank you, Gia. Thank you, Sarah, for scribing, and Ashutosh again for the teaching points. And as an FYI, tomorrow for RLR, for those of you who are used to the regular time, it's a little bit unusual. We're starting at 10 a.m. Eastern time tomorrow, so 2 hours before we usually do, and hope to see some of you there. Bye.